Valley Healthcare District to pledge our efforts and our attention to those things that would be of betterment here through our efforts and through the efforts of those who work and give care to the visitors and residents of the Kern River Valley. We ask you, Father, to bless us as we take these items on the agenda into our minds and hearts, that we might be able to understand thy will concerning the things that we do, that we might be able to progress and carry forward this healthcare district and the services that it provides. We're grateful, Father, for this beautiful valley, for the things that we have, all the necessities of life, all the wonderful things that happen in this world. We ask you to bless us to be thankful and bear record that we are being blessed by thee as we do those things that thou would have us do. Take us throughout this meeting as we dedicate it unto thee. And this we ask in the name of thy Son, Jesus Christ. Amen.
And the mission statement will be read by Director Elliott this evening.
Our mission statement is that we will provide high-quality, efficient patient care services that respond to community and provider needs. We will provide leadership and health promotion and education for our patients, residents, medical staff, employees, and community throughout the district.
Okay, thank you, Director Elliott. Item D is the closed session report. Scott Nobby, legal counsel.
Yeah, in closed session, the board considered two items. The board considered the application for leave to present a late claim submitted by John Timms. The board approved the application to submit a late claim and then rejected the claim that was submitted. In addition, Chief of Staff Finstead presented a medical quality report. No other items were discussed.
Okay, thank you, Scott. Item E is the public comment portion of the meeting. Is there any public comment this evening? Going once, going twice. Okay, thank you very much. Item F is the consent agenda, and Director Parks did want to pull the governance committee meeting minutes of October 29th, so we'll move that to new business. Just to talk about the strategic planning, which I neglected to put on the new business portion, so we'll put that as item 7 under new business. The minutes will still have to be approved when we get there, but just for the record, we'll make sure to add it to the agenda next month for strategic planning and board retreat. Was there anything else besides that needed to be pulled from any member of the board? Or?
That part where Chet was talking about the bond union, that's separate, right?
That'll be in.
Okay.
That's just
Okay. Make a motion, we accept the rest of it.
Second.
Okay. Been moved by Director Parks to accept the consent agenda minus the governance committee meeting minutes, and it's been seconded by Director Cassis. Any other discussion? Okay, hearing none, all those in favor?
Aye.
Any opposed? Okay, the consent agenda is passed and carried. Moving on to item G, reports, the foundation report. Ms. Hess? Oh, I'm sorry.
Yes. I figured I've been doing this long enough where I can say something and it makes sense. Mr. Chairman and members of the board, members of the public, I am really pleased tonight to talk about the foundation. I've had an opportunity to dig into some of the records with the help of Debbie Hess and Jeanette Rogers-Erickson and some of the other people that are on the foundation board. And when you look at the achievements of this foundation, they're pretty special. The first thing that comes to mind is the Jeanette Roger-Erickson Heart Walk. 21 years, 22 years we're coming up on? Yes, that's amazing. And every year they have done extremely well. And we hope that continues. The River Rhythms, which I have to say slowly, for scholarship money to help those people who would like to enter into the field of healthcare or public safety. This is so important. Schooling, today I have sometimes a difficult time grasping the fact that you go to school and you go for a number of years, and when you graduate, you have all this debt behind you. And if we can do anything to help lessen that burden, we would like to do that. The diabetic cooking classes, I was diagnosed with diabetes about 6 months ago. And I thought, oh my God, I can't eat anymore. Well, you can, and you can eat well. So I think that's a great thing for this community to take up and to continue. And it wouldn't hurt for everybody to eat that way, quite frankly. It's a good thing. Transportation, we partnered with the hospital auxiliary and purchased a bus. I believe it's 15 passengers, is that correct? And it's to take the skilled nursing facility residents, and they travel to various locations. They've left the county even. They went to Eagle Mountain Casino. They have gone to various locations for recreation. They've gotten to be tourists in new locations. And River Rhythms. They loved River Rhythms. And they've been out to dinner. And Susie, thank you. The people in that facility love you, and you are never allowed to leave. It was in your contract in the fine print.
I forgot to read that.
We've also purchased some new furniture for the day room and created a fund to help pay for activities off-site. We are in the process of planning a public safety workshop along with a luncheon that's going to be funded by a grant from, it was Edison, is that correct, Debbie? The biannual wine and chocolate event is coming up February 12th, 2020. It's always well attended. Everybody loves chocolate. Most people love wine. There's nothing to complain about at that event. And we hope to get the word out not only about the foundation, but hospital services as well. In the near future, we are looking to create an endowment to ensure sustainable funding for the future. And I think we're pretty close. We're pretty close to having everything in place to make that happen. We still have some more questions, but they're questions that I don't think are deal killers, if you will. And we'll soon be able to put some money into that endeavor and to have some sustainable funding and build on that. Help pay for tuition for CAN training, assist with extended hours for the mobile clinic. I'm not sure if anything's been settled about the mobile clinic, about when it's going to arrive or when, how many hours it's going to be able to function, but whatever it is, we would like to be able to be in a position to say, let's stay out there a little bit longer because we have the funding to make that happen. Doctor recruitment, I'd love to be able to put together a program where we can recruit doctors that would love to come to the Kern River Valley and work where they play. There are a number of wonderful things that people can do in the Kern River Valley, and they need to learn about them as opposed to just coming here and looking around and in some cases seeing situations that does not please them. We have a lot to offer. We have all of the sports. Debbie and I went to lunch at the Kern River Brewery the other day. Eric Giddens has a doctorate degree in marine biology. He makes beer. And he has a great time doing it.
More money.
Yes, there's more money in the beer. And of course his wife, Rebecca, we all know she's a silver medalist in the Olympics, and they chose to live here. Rebecca chose to train here, and what more can you ask for? I think what we need to keep in mind as this foundation looks for more creative ways to make things work is just to know that we don't know what we can do until we try. Do we have any questions?
Are there any questions for Ms. Hyde?
No.
Okay, thank you.
I
very
have
much.
one request.
Yes?
If we could get notification on meetings, I tend to get lost in space.
You do?
And
Okay.
I've been conspicuously absent, I'm sure,
Definitely.
way too many times.
We will put you on the list.
Because I do love, I love what the board does.
Thank you.
Thank you.
Likewise, thank you very much, Judy.
You're welcome.
Item 2 is the auxiliary report. Cindy Rubert, our auxiliary president. Welcome.
Good evening. Well, I don't have a long report today, but, if you're looking for Christmas, come on down to the thrift store because we've got Christmas, and we've got Christmas, and we've got Christmas. But the only thing we haven't put out yet is the trees, because that's a little early to set those out. But Tony Easter Day is working really hard on getting the stuff out of the shed that we took all year to pack into it. December 11th, mark your calendars, because at 12 o'clock noon, we're having our Christmas party over at the Eagles again, and you are all invited. That's all I have.
Any questions for Ms. Ruger?
Thank you.
None, thank you very much.
Thanks, Cindy.
Great job.
Item 3 is the medical staff report. Dr. Finstad, Chief of Staff.
Thank you. The Pharmacy and Therapeutics Committee met on October 18th and reviewed and approved quite a number of policies. These included infection control and skilled nursing facility vaccination policies, policies regarding nursing interventions in the emergency department, policies regarding compounding sterile preparations in pharmacy, along with quite a number of policies from the laboratory about how their equipment is to be used. One policy was retired regarding RNs ordering testing in the emergency department, and that was replaced with a much more improved policy. Standing orders for influenza vaccination for the skilled nursing facility residents was approved. And the committee also reviewed the regular monthly and quarterly reports, including blood usage, blood culture results, medication usage, restraints, Foley catheter usage, and MRSA monitoring on acute care and skilled nursing. The Medical Quality Council met on October 22nd, and information was discussed regarding the risk summary for second quarter, the skilled nursing facility monthly quality assurance reports, and third quarter national patient safety goals were all reviewed. The emergency department met on October 23rd and reviewed their usual reports, including decision to admit studies, medication usage, blood culture analysis, and analysis of CT angiography that were done in the emergency room. The Skilled Nursing Facility Quality Improvement Committee met on October 24th and reviewed and approved policies regarding the influenza vaccination and medication and laboratory monitoring for medications that the residents are taking on a yearly or on a regular basis. The standing orders were approved for both influenza vaccinations and also for pneumonia vaccines. The facility is now doing both the older Pneumovax and the newer Prevnar 13 pneumonia vaccine, which is a big step forward as the new vaccine is significantly more effective. Also, the regular reports were reviewed, including the Department of Public Health Plan of Correction tracking, quarterly statistics, hospital-acquired infections, hand hygiene, and medication usage. The antibiotic stewardship component of the meeting was held after the main meeting. Antibiotic stewardship has been a very high visibility item in acute care for quite a number of years, trying to assure that medications are not inappropriately used. Things. That program is now being expanded to involve the skilled nursing facility and things, and so they're kind of getting up and running on that program. The Medical Executive Committee met October 29th and approved a number of new applications. Also approved were reapplications for the telemedicine radiologists. In addition to that were the policies that were reviewed and approved that were on the consent agenda. The Utilization Review Committee met on October 30th and discussed issues including denials of payment and authorizations. And then the Emergency Department Committee met today, November 6th, and reviewed and approved a new policy regarding increasing the scope of respiratory therapists in the ED, along with the patient admission process. And that's the end of my report, unless there are any questions.
Okay, are there any questions for Dr. Finstad? Okay, hearing none, thank you, Dr. Finstad,
thank you.
for that extensive report. Item 4 is the Chief Executive Officer report, Tim McLew.
Thank you. Just a quick update on AB 5. This is the legislation that was signed into law by Governor Newsom. It takes effect in January. This is the independent contractor bill, which you've probably seen a lot of conversation and discussion in the newspapers and on TV. This is a bill that was ultimately derived to trying to change the reporting relationship, like for Uber and Lyft and some of these type of employees are independent contractors, to make them employees. The bill was really a shotgun approach across all industries here in the state of California. There were only about 4 or 5 major exceptions that were made for people that would not be considered an issue for independent contractor staff, which was attorneys, physicians, architects, and engineers, I believe, and so and accountants. And so everybody else kind of came under the auspices of this bill. So what we're required to do is we're going to literally going back through all of our contracted services, because this impacts how we provide services through our CRNA, which is our certified nurse anesthetist. We have to go back and relook at those to see whether or not they meet the clause, because either they can stay as an independent contractor, or they have to become an employee. Also has implications for possibly people that we use through telemedicine for our psychology and social work that they do, and from a counseling perspective, potentially biomed, services that we provide for equipment and so forth. So we're going to literally go through every one of our contracts to look to see where we have services that are provided by independent contractors, and to see whether or not they actually meet the requirements to be considered as an independent contractor. If not, then we've got to look to how we can change those relationships to make them compliant. So that's something that's going to be in place. The Hospital Association is going to be filing some bills very shortly, once the legislature is back in session, to begin putting some further clarity in play as it relates to the healthcare employees and so forth. This has implications obviously for our nurse registries, because they're technically independent contractors to us, and so they don't. There's the 3 tests called the ABC test that you have to look at, and the very first item on there is that they act independently of the hospital that's part of the business that's contracting with them. Obviously, nurse registry staff operate very clearly under the direction of the hospital, and so they would not be considered independent contractors. And so anyway, so there's some changes that need to come down in the legislation very shortly. So we're working very closely with the Hospital Association on that. Pleased to announce that we have signed an agreement to participate with HSAD, which is the Health Services Advisory Group. They are a group that's funded by CMS that aims to look at improving patient outcomes and so forth. This was a free service to us. The commitment and the goal was to try and get all hospitals in the state of California to participate in this. The commitment was a 5-part commitment that we had to make. One was to decrease opioid misuse and improve behavioral health outcomes. 2 was increase patient safety. 3, increase chronic disease self-management, and that really was in the area of cardiac, vascular, and diabetes. 4 was increase the quality of care transition, and then 5 was improve nursing home quality. And so those are things that obviously are very concerning to us, and obviously any tools that this group can bring forward to kind of help us in our efforts on any of those areas is going to be greatly well received by us. And so they actually are going to be comparing data that they have collected nationally through their sources that compares us to other areas, and that we can have best practices and we can identify how others are doing things. So we're very anxious to participate on that. We actually have another program that we participate with HSAG on, which is more of a quality care, how would you describe that?
They just collect our data and then compare us to other facilities related to falls and related to
Some of the CAP
counties
scores
and
yeah,
CLABSIs,
yeah.
the central line bloodstream infection rates.
See how we can improve some of
And,
those. And we, some of them, again, as we had a meeting on that this morning, and some of those, we were probably industry best, you know, in terms of the results, just because of how we do things here and some of the results we've had with county infection rates and surgical site infection rates and those kinds of things.
It's hard to beat zero.
Yeah, exactly. And so, anyway, so this is the second project that we'll be taking on with them. Pleased to report that we received notice from Beta that because of performance of the hospital as well as the overall group insured through Beta, that we've received a dividend of $158,000, $158,361. We've received the first half of that already. Second half will be mailed out on April 1st. And so that was welcome news.
That's great.
Absolutely. I sent a letter to Representative Kevin McCarthy in support of efforts to prevent cuts to hospital dish payments. This is a huge issue. There's been a lot of pressure being applied federally to cut the dish payments, which would have a disastrous effect on a lot of the rural hospitals. Our hospital does receive dish funding and so forth. So through the hospital council, they are sending letters to all of the representatives in the state assembly. And so the issue, or actually the House of Representatives, excuse me, since Kevin McCarthy is our representative, because all of these were ultimately to be compiled and then sent to Kevin and to Nancy Pelosi. And so I said, since he's kind of our person, I'm just going to go ahead and write him directly. And so we did that. And so hopefully, I think, you know, he's behind this effort to try and help save that funding for the hospitals here. So next thing was just flu shots. We've received those. We've had our flu shot drive, the drive-through. We've gotten, almost most of our staff has gotten their shots already. There's just a small handful that have not yet notified us of what they're going to do. We've had probably 6 to 7, 8 employees who've opted not to get the shots, and they're going to wear the mask from November 1st through April 30th. And that's their choice. And so anytime they're in the hospital, anywhere in the hospital, they have to wear the mask. And so and what's, Greg, the plan obviously with the leftover, that's going to go to the clinic and those are going to be made available to people in the
Yeah,
community?
we're already administering them
Great.
to patients.
And the SNF, they've gotten their,
They were taken care of before the employees were.
great.
They were sent over, allocated.
Excellent.
Pink ladies will be next.
Mark ordered some long names.
Long them.
Like this.
On October 3rd, we had a meeting with our, on our IT risk assessment. Again, this is a contract that the hospital did with CPSI to come in and take a look at opportunities for data to be lost or corrupted or whatever from outside the facility, whatever. So there's a long list of action steps that were taken, and so this was him the consultant coming back and meeting with us. Actually, it was a phone call that we done this one, to go over that list and so forth and get an update as to where we are from a progress picture. We're on track right now with all of the corrective action plans that need to be made. There's a couple of items just because of cost issues that we've decided that we're going to go at risk on, you know, and it just doesn't make sense to go ahead and do some of those things. But for the most part, we have good action plans that Kerry's been working on, his staff, and a number of medical records people and all over. And so pleased with the action that's going on there. Last thing I had was really just had an opportunity this last month. We participated in all of the staff meetings with the skilled nursing employees. That was four meetings, 7:30 in the morning, 7:30 at night, on Friday and the following Monday. Got some terrific feedback from the staff, obviously. We want to stay very close, connected with them in terms of what some of their issues are, and do everything we can, obviously, to be as responsive to their needs as we can. Some of those things that were identified as those meetings have already been addressed and are being taken care of. And so, and as I shared with them, my plan is to become and do this on a much more frequent basis. Mark is going down in the morning to try and stop and see how things are going down there. I try to get over there in the afternoon when I can, and so forth. So it's just, again, just a lot of issues going on, and we just want to make sure that the staff feel appreciated and so forth. So, and the last thing, again, one other thing we had was, I want to thank Susie also for we had a car show here about a week or so ago. What was that?
I said I forgot about that. I've slept since then.
That was,
rearview mirror, right?
I think a year ago we had 7 or 8 cars.
We had 12 last year.
And so this year we had over 30 cars show up. These are the old, refurbished, rebuilt. I mean, they're beautiful, absolutely beautiful.
Next year there'll be 31.
We might have to get a bigger parking lot.
But the residents were taken around to see the cars and stuff like that. It's just, it was a tremendous event. So again, everybody appreciated that. So
Thank you.
Nice job.
Thank you.
That's my report.
Yeah, are there any questions for Tim? Tim, did you want to talk about the seismic bill?
Yeah, one of the things, like I said, I handed this out before the meeting. Primarily, what it was I mentioned before that the Senator Portantino is writing a bill. He started this last legislative session. It's SB 758, which was an effort to go back and rewrite the seismic update law or retrofit law that right now basically requires every hospital in the state of California to meet seismic compliance throughout the hospital, or at least throughout the acute units and so forth. In the state's looking at this, and through the Hospital Association and a number of other places, the cost associated with that. Rain Corporation just did an update report this last year, identified that the cost can be upwards as high as over $120 billion to replace all those facilities. And so when we stop and take a look at that, again, a lot of the facilities statewide, we go out and spend millions and millions of dollars to do this, even when they're not in a seismically active area. And so, and the costs can be dramatic. I just, as a frame of reference, was at a function a week or two ago, and met with John Van Boning, and he kind of asked me how things were going up here, and with seismic and so forth, and I shared with that with him. And he says, "Do you have any idea what our costs are for Memorial Hospital?" And I said, "I haven't a clue." He said, $200 million to seismically upgrade Bakersfield. That was just the one facility. So, it's huge dollars.
KMC was close to that too, right?
Yeah, I don't know what KMC is yet. I haven't talked to Russell about it. I know what he's got to do, but they're still working on their plan. But that was the first time I've actually heard from another hospital CEO what their actual number was looking like, and so forth. So, again, Portantino is understanding this. We're looking at that. Again, when major disasters happen, I mean, you see it in the news all the time. There was something that happened the other day down in LA County and at Cedar Sinai, and they had the tents set up outside of the streets and everything else. And guess what? That's what happens in a major disaster. The triage areas and the tents are all set up outside. You care for them out there because you can't have everybody coming into a 7-bed or 7-bay ER, or a 21-bed ER down in Bakersfield. When you've got several 100,000 people that are going to be impacted down there. And so, again, we talked about it from the perspective of trying to, be smart about how we spend the money. There's a lot of ways that you can bring resources into areas that are affected by an earthquake. Obviously, the recent earthquakes that we had out in Ridgecrest, brought a lot of this to light. It also had some other issues that came to bear because the damage at Ridgecrest was in the retrofitted building. Anyway, the bottom line is that Senator Portantino has recognized that effort. He is rewriting this law to primarily require hospitals to seismically retrofit their ERs, their ORs, and their post-operative recovery areas. That those are the three areas that are most important in a hospital disaster. And so, and he is one of the head of major committees in the state senate, and so has a very good reputation and so forth. And so, again, I think that's why the hospital association is working closely with him to try and draft this bill. So what I handed out to them tonight was the actual current version of the language of that bill. It was actually introduced last year. It was converted to a 2-year bill, and so it will carry over into this new legislative session that's getting ready to start. And so I'm sure there will be a flurry of activity coming on to try and continue to modify that. But you know, some questions came up last time, and I said I would get a copy of this to the board, so I've accomplished that.
Thank you, Tim.
You're welcome.
We'll go to Debbie, then we'll go to.
Tim just had a question about 2 acronyms.
Yes.
What is a beta dividend?
Beta is our general liability insurance company
Oh,
and workers' comp.
It's actually a captive insurance
Yeah.
company that's owned by the users.
members, right?
By the members.
We were one of the founding members.
so you have good performance and you get some dividends back for that.
Correct.
And then dish funding, what's dish?
Disproportionate share hospital. And I'll let you talk about that if you want more information.
I can find out now, thank you.
For hospitals that say a disproportionately large number of Medi-Cal or low pay or no pay business, there's additional funding that's made available,
Oh,
in essence.
I remember now, thank you.
You are.
Back to the question about you guys attending the staff meetings for the skilled nursing and stuff.
Yes.
Can you relay what some of their concerns are?
Issues obviously had to do with, obviously, number of staff. That's the single biggest one, is obviously the number of CNAs. And we've talked about that at length here, and the strategies that the hospital's employing, and Mark will talk a little bit about that in his report. Issues associated with just communication style down there and how messages were being delivered and so forth. Those we've had a number of communications on since then. There are issues associated with housekeeping in terms of the fact that they didn't have a big enough trash can. They had one big trash can at night when they were collecting the trash from the patient rooms that went into, and so it would spill over onto the floor and so forth. So this was an issue for them. They said, fine, we'll go get you a second trash can. And so that's been ordered and should be here shortly. Some issues with dietary as it related to sometimes when special order trays were made up, they would bring the dietary tray over, and instead of letting the nursing staff know that the tray was there, the dietary worker would just walk off, and so the tray would get left there sometimes, and the patients wouldn't necessarily get it right away when they're waiting to eat and so forth. And so those issues have been addressed. Just a whole host of things that they went through.
And so the staffing issue, what is the ratio right now with the CNAs to patients?
We're in compliance with the ratios of 3.2. It's 3.2 hours per patient day.
For the license.
For the licensed staff, right. That includes RNs, LVNs,
CNAs.
CNAs, right.
Okay, thank you.
You're welcome.
I just have a quick, I just wanna say kudos to my staff for helping with that car show. If I am nothing without them,
Absolutely.
so they worked their butts off.
They did. They
I
made a
can
lot
say
of phone
that.
calls and so forth.
It was pretty amazing,
It was.
so.
You had Mark working too.
I did.
We draw the line at pie. I don't see that.
I know, pie in the face,
I
I mean, we
didn't,
didn't get a
get
pie in the face. You did one year,
You did.
And that's
couple
why I
years
didn't
back.
really get it.
yeah.
So are there any other
And,
questions for?
and my
Tim?
volunteers too, sorry,
Absolutely.
right here. My chopped liver, she said.
And I was there till the end.
She was.
Are there any other questions for Tim before we move on? Okay, thank you, Tim.
You're welcome.
Item 5 is the Chief Nursing Officer report. Mr. Gordon.
So, good evening. So my report is going to begin with local facilities around the community are joining forces to apply resources to the opioid problem locally. The hospital's doing its part. We're evaluating our prescribing practices in the ED, and I am happy to say that prescriptions that are going out of the ED are decreasing exponentially. We have a really good effort as far as making sure that patients are. Some of the statistics that I heard about back in Phoenix when I went are 25% of the young people that are basically in high school that are started on an opiate will still be on an opiate a year later, which is, interesting to me in that that's kind of an addictive behavior. So 25% of those people become addicted or can become addicted to that type of medication. So we're trying to recognize that, and obviously we're treating pain appropriately, but we're also very aware of what's happening in the communities. So the other thing is how we can appropriately manage prescribing of Narcan. Some of the communities that I heard from at this conference are actually requiring prescribing Narcan with opiates that are being prescribed. So it's Narcan is a antagonist, which means it reverses the opiate effect. So if somebody's an addict or something like that, they're actually educating the family on how to administer the Narcan. It can be given nasally or it can be given by injection. So they're working towards catching those people when they overdose so that we can reverse that. The other thing is we're also trying to look at medication-assisted treatment programs, and those are a little bit more difficult because you have to have cooperation from providers in the community. You have to have really good payer sources that are willing to, a payer source like an insurer would rather buy a 25-cent Norco than they would keep a person on a medication-assisted treatment program for 2 years to get them off of some sort of an opiate addictive drug. So it's difficult. I was a little bit discouraged when I went to that, frankly, when I went to that Phoenix conference, but we're looking at ways to try to encourage the community resources at large and Chris Riley had a meeting, I think Debbie was at a week ago, a month ago. Lisa Wiley went to that. And so the resources in the community are trying to band together to kind of address this problem.
Just a point there again. And one of the things we've learned, again, a lot of this starts with the emergency department. Again, because it's typically where people are coming in with acute pain and issues and so forth, that the natural first response was to put them on an opioid. And once they get on it kind of builds from there and so forth. And I think that's one of the things that has really been impressive by the data I've seen from Mark with regards to the efforts in, identifying, the physicians, their ordering practices within the ED and reporting to them on a monthly basis how many were ordered. And even though that was blinded, they were stunned, and so it was amazing how quickly the practice changed. And sometimes that's the beauty of a little information is that people really
shine a
don't
light on
realize
something.
Exactly. Once you shine the light on, people say, "Wow, okay, great." And so we've seen a big change in that. So very pleased by that.
We've submitted our application to the CNA licensing board and received notification where we need to make some alterations in the scheduling of that program, and we are on those. We've made those appropriate changes, hopefully, and we will resubmit on Friday this week to get that done, and so tomorrow.
I think one of the impressions.
I'd say Thursday.
Right. Tomorrow, if we can get it out tomorrow.
I like that better.
I think what's interesting to see, because before, anytime we dealt with anything with the licensing board, I mean, it would take forever to get a response back. And I think the first time we submitted they send back a letter within 2 weeks, I think it was, that, hey, you've got some changes we'd like you to make to some of the curriculum items and so forth. And then I think the second time was, how quickly did it come back?
That day or day after that.
So, yeah, so I mean, it's really showing that the state is wanting to get these programs open because they realize the crisis the state is in.
The other thing is that I would add to that is Gina Patterson, who is the one who approved our grant application for the CNA Kickstarter program, has also emailed me just today telling me if we need any help, any assistance in preparing that application, that just reach out to them. They're more than happy to help us make sure that gets approved and put together correctly. So we're hopeful for that before the end of the year, that we'll have that application approved. So on the last thing I do want to touch on is the CNA. That's pretty much primary on our radar right now, is getting certified nursing assistants to our facility. The cost of a CNA through a registry is outrageous. Chet might want to comment on that, he may not want to comment on that. But the reality is we do have CNAs from registries, and I frankly, I have to say they're not very, they've been unreliable, they've been not the best employees. We really want our own employees, we want them trained here, we want them educated here, and we want them local so that they have retention ability, or retainability is probably a better word. So we've been thinking outside the box, trying to come up with incentives. We're advertising in Ridgecrest, in Tehachapi, and soon we'll be in Bakersfield to discuss our own travel registry, I'll call it. And it provides incentives for people to make us more attractive on a 13-week contractual basis. And so I don't want to discuss numbers right now, but I am hopeful that we're going to hear back from some people that are interested in making, in applying for one of those 13-week travel assignments through our own basic travel registry. So Chet was pretty creative in that thought process. So it really, I think it'll attract some attention, and we're hopeful for that. The last thing I want to talk about, are there any questions about that before I move on? Go ahead.
Are we offering our current employees anything that is going to keep them also? I mean, it's just like DirecTV to me. If you're going down the street and they offer DirecTV, you're going to get more perks as a new person than you are as someone that you already have the. So I'm just kind of curious. Are we offering?
I'll let Chet speak to that.
We actually did a special salary increase. The board approved for us to increase the rates for our CNAs locally that we already have. We did that as of July 1st. That was not something that is normal. It was simply to raise the price to try to for retention and also to recruitment.
I'm just curious. I know they work hard. It's a hard job.
Oh, very hard, very hard.
And they deserve for what they, a good wage for what they do. So, thank you.
I would agree. So the last thing I want to talk about is recently we had, I don't know what the date was, Bob, can you help me with that? Doesn't matter.
No, off the top of my
We had a multi-agency seismic drill. What was we had a seismic event, and it created a fire in our upstairs mechanical room, and we had 5 of the engines respond to our hospital. It was pretty awesome. Were you here for that? Did you come around? You did.
You got pictures.
Yes.
You got pictures.
That's right. That's right. She was right here in this room. And
Every fire station around the lake plus Inyokern played in the drill.
It was pretty awesome, and so we.
There were phone calls received.
If you want to see what the fire looks like or looked like, that they had to find, because they weren't told where it was, they had to actually investigate and find. Bob has a picture of that on his phone, and he can show it to you later. But that drill was very successful. We learned a lot of things about how our little walkie-talkies that are in this cabinet right here, they don't reach all the way over to the other side of the building. You have to literally walk outside to communicate with Dewey on the other side of the.
Some of the older ones, yeah.
So it was pretty interesting. We had a fire chief here that was kind of conducting his guys, and we were very good communication with that, and I think it was
Unified Command, it's called.
Unified Command. That's what it is. I took Hicks.
Yeah, I know, but we forget those terms
That's
sometimes.
right. So I think it was definitely a good exercise. We got a lot of good response. If you see this board, it was basically covered with all of the kind of the different departments that were reporting in on the whereabouts of their people and the staff and the visitors. We had to remember and account for all these bodies in the building. If there's a fire, you gotta do that. So we were very pleased with the outcome, and we learned a lot of stuff. And yeah, we think
we added in what Ridgecrest had, which was broken water lines, and so
sure.
areas had to report that they had water leaks, and responses were made. And
some people brought some of their own scenarios from their own departments, and so.
And it wasn't them shooting water on the roof.
Right, I got to be the incident commander, which you can have that job back if you. No, it was
And we
actually
still
very
did
fun.
well for meetings of
It was,
April.
and we still did well. Yeah, it was actually very enlightening, very fun for me to.
You did a good job.
Participate.
You did a great job.
So.
Could I make a comment about that?
No, sir.
You tied up-
Absolutely.
You tied up traffic on Dogwood.
Too many fire trucks.
Hey, Mark,
Sorry about that.
a question on that. Is there any kind of after-action report on the
Yes, sir.
drill and?
yes,
and so
I will be putting all that together with
Great.
pictures and because we had an after-action meeting, everybody gave input. I have all that compiled, now I have to put it into a written format and attach pictures, and then it all goes into a binder.
So one of the things that we did during the exercise that we had a problem with the last exercise we did was we didn't have somebody available to us to record all of the activities that was happening. So the thing that I did different was I had somebody putting down all of the activity on this board, but I also had somebody sitting where Nick is back there, actually doing a live recount of the time that everything happened and everything, and so she was really adept at putting that all together. I ran it almost like a cardiac arrest kind of thing. I wanted a recorder to be able to know what we were doing at any given time, and we had Brandy, who was very good at just taking notes and putting timestamps on everything that we did. It was very, very well done. So Bob will be putting all that together when he has a spare minute.
The important part, I think, from our perspective was that, again, and a lot of this went back to the Erskine fire, you know, where literally for 2 or 3 days, nobody from the fire department stepped in here or even checked in to see how we were doing. And so that kind of tells you, you know, the issues of communications. And, you know, Mark, about a year or so ago, began hosting a quarterly first responders meeting that had fire department involvement, the sheriff's, you know, ambulance companies and so forth. And that really began helping out some of that communication links. And so they actually, the fire department actually approached us and wanted to do a drill
During one of those
with
quarterly
us,
meetings,
because
yeah.
this is one of the more complicated buildings that they have to work in anywhere up here. And so just being able to, how do we get hoses through the hallways and up stairwells, because there aren't a lot of multi-story buildings here. And so that was really what they were hoping to practice with it. And I think they were very pleased with the outcome, and they are committed to do
The
this
fire
again.
captain's comment was that they felt it was a very successful drill, very good from their standpoint, good for training on their side as well.
And it also had impact on communications of how we communicate with them in terms of how do we pinpoint exactly where to go.
Yeah.
Because obviously our building is segmented to different types of buildings. We have building G, building A, building D, you know, and so forth. So they now have maps of the hospital and so forth. And obviously as we communicate, you know, locations of the fire or the incident, they can get right there and obviously spend less man-hour time hunting around. And so that was really important too. So there's some really, really good takeaways, I think, with regards to it from both parties. And they've committed they want to do more future drills with us. And, you know, we're all for that. So
So would it be possible for the board to get that after action report at one
Yeah,
point when you could
Absolutely,
compile it?
as soon as I have it done,
Yeah, thank you.
which shouldn't take too long.
Are there any questions for Mark?
Thank you, that's.
Thank you, Mark. We'll move on to the next item is the chief financial officer for checking.
Nothing's changed.
Tonight, we'll talk a little bit about the operation numbers for the month of September and year-to-date through that period. And I want to start with one of our bright spots, something that hasn't happened in a very long time, which is our acute unit, actually both for the acute and the swing bed patient days saw a fairly robust increase from what they had seen, and I'll talk about it. For example, in our acute beds, we have been averaging close, but not over 4. We actually went to 4.1, and last year at this, for the same month, we had 3.4. And as an average for the 3-month period, we are at actually 3.8, pretty close to what it was the year before. With our swing beds, and I'll talk about why. Actually, the month of September of 2018, we had no swing bed patient days whatsoever. And this particular year, we had 85. That's a 2.8 average daily census in swing beds. It's something I'm hoping we continue to do. The reason for it happening, for the most part, not totally, but for the most part, is that we have had some problems that were just alluded to in the staffing over at the availability of CNAs over in the SNF. Consequently, we've had to, based upon our inability to, or our ability to keep up with the target of our of Title 22 for our staffing, for licensed staff, as well as our inability to increase the census over there. Because of that requirement, we basically had some patients that we kept in the skilled, or in the acute medical surgical area. And so that was part of our swing bed census. But what it did, and I'll get to the numbers in just a minute of the dollars, and in fact I'll even turn it over to you. I have not seen us beat the budget in the revenue generated in the medical surgical unit for more than 2 years. We did in the month of September. To give you an example, the prior year for the month of September, our revenue generated from our medical surgical unit was $821,000. I budgeted for us to do better at $1.1 million. Okay, we actually did $1.2 million in revenue generation in the month of September. That was huge as far as I'm concerned, because we just haven't seen that kind of performance, and it mostly related to the fact that we had some of those swing beds patients that we would like to see, and we normally should be seeing in a critical access hospital. From there, I want to go down to, however, I do want to talk about the length of stay. As you know, in an acute beds, or you may or may not know, that in a critical access hospital, by statute, you cannot exceed as an average daily census of, or this is annually, of 4.0 for your acute, or excuse me, length of stay of 4.0 for your acute days patients. They should be staying longer than 4 days. We were at 5.9 for just our acute, not the swing, okay? Just the acute for the month of September. Now, on an average, we're still at we're at 4.4 for 3 months, but by the end of the year, we need to keep that at about 4, but still keeps SNF patients in there for a certain amount of time. The swing bed patients, the average length of stay for swing bed patients in our medical surgical unit was 85 days. Obviously, those were SNF-related patients because your swing bed should stay no longer than about 10 days for therapeutic services. So you can see what I mean by that, but it's a situation where we just need to watch the two things, and there needs to be some balance there if at all possible. Our long-term care, as I said, we actually, because of our situation, discontinued admissions into that particular unit in the month of September and also in October. So we were actually but we actually had an average census of 56.9. The year before that was 56.7. So even with an open unit and a closed unit, we didn't do much different in our census, even though we would like to. So our big thing is to get the CNAs available so that we can put, start a growth pattern there, but also what we used to do back in the old days when we were running, instead of running at 70% or 80% occupancy, we're running 90. We used to always keep a couple of patients in the acute unit, and then when we would have a patient who expired over in the SNF, they would be transferred over. That's the right way to manage the unit if at all possible. You want your SNF units to be 90% occupied. In the emergency room, we continued to, in the particular month of September to see a good volume. We had 646 emergency room visits in the month of September. We had 605 the year before. The problem was we only admitted 3.41% of the patients there. We are starting to watch, actually we have had not a good month starting in November. Already 2 days this month we have transferred 4 patients in 1 day, twice already. We need to take a real hard eye at what's going out and the clinical aspects of that, and could we take care of it here, or if we can't, what we need to do to be able to do that, if possible. So it's becoming a real problem. In my mind, our percentages of admission are going down, and we hope it's not just easier to send a patient down to Bakersfield than for us to do what we need to do to keep the patient here. In our referred outpatients, that continues also if you're doing well in some of the other areas like our clinic, and we have actually done extremely well there. We had over 1,700 visits, 1,400 of which, 1,434 of which were for primary care, and 302 were for specialty care, which includes mostly our behavioral health, our medicine patients, then in addition some cardiology, some general surgery, some of the endocrinology patients. So we have a little bit of that as well there, but our clinic is doing extremely well. We're almost ready to get our mobile unit in. We may even have to, the board has approved for some fencing to be able to kind of make it so it's more accessible for, if we might even have to use it for patient care over there at some point. Right, Greg? Yep. So that's our growth factor in both cases. Now, in the fully allocated product lines, we were very close, but we did not make money in the medical surgical area. But effectively, other than the ER makes money almost consistently simply because we have a high intensity of ancillary service in the ER. So, on a fully allocated basis, they normally make a pretty good buck. But our second highest net profit producing service now is the rural health, or the mountain I'm gonna say the Rural Health Clinic simply because it has other aspects to it. Okay, so Mountain View. But actually, the other thing that's happening is our surgeries, along with probably most places, small hospitals, are on the decline. More things are being done non-invasively than invasively, which is a good thing for patients and probably a good thing overall. But we are seeing that also specialists that used to come don't come and come less frequently and have less patients when they do come. So that's going to be an area that we have to focus on. Although that's something, as Tim said, that has to be in the, or probably will be in the seismic compliance. We're already fairly seismic compliant there. We have some small things to do, but effectively we've done a lot of good things to manage it. We're losing money hand over fist there before and trying to run it like a surgical unit in a larger hospital. We fixed that, but we're still going to see that decline, and it's still going to be problematic. The other growth area that we have going on is we're kind of coming back in the retail pharmacy. It's gaining ground again. It's actually up to 3,512 prescriptions filled in the month of September versus 2,581 in the same month of the prior year. That's a good increase. We have some work to do, a little work to do on inventory control, but outside of that, it's apparently patients are beginning to feel good about getting their scripts from us, and the way it's being run by the pharmacists in charge down there. Let me go to the money for a minute. I talked about the inpatient revenue. Another area that was even more over budget, and I talked about the clinic and their profitability. Well, they were $177,000 over budget. They actually generated $1.5 million, where a year ago they only generated 1.2. So that to me is a very good increase. Our outpatient revenue is about the same as our budget, but it was also higher, 4.7 versus 4.3 million in the prior year month. And the retail pharmacy, actually, as I said, at 147 versus 132,000 in the prior. So we actually generated $9.7 million in revenue in the month of September versus 8.6 actually in the same month of the prior year. Interestingly, even though you may have intensity of service, some of that depends on the financial class that you have in your contracts. And actually, our percentage of our allowances, discounts and allowances, was greater than it was a year ago. So a year ago, we generated 2.2 collectible out of that 8.6 million. Out of the 9.7 million, we only actually have collectible 2.4. So you don't get quite as much. Your deductions with the intensity of service does go up. On the operating expense side, we actually were $161,000 under our budget in operating expenses. Actually, mostly in the area of purchase services, as well as repairs and maintenance, interestingly. But it's a situation where we have been doing a fairly decent job there, I think, in managing it. And actually, overall, we were under budget in salaries and benefits. And substantially, not dramatically, what we have in our revenue side is about 7%. I put in a 7% the board approved, and in my budget, I put in a 7% price increase in the 1st of July. I normally put in something like that, knowing that probably half of it's going to go away. If things work right, 3.5% will go to the bottom line, and 3.5% will go into deductions, because that's the way it works with contracts. So we did that. We got, and actually on the expense side, put 4% in for salaries. We don't start them right at the beginning of the fiscal year. It happens based upon their timing for merit, which is an anniversary date, and also then our parity review, which basically we're involved in right now. And even with the increase that we did, I mentioned that, a special increase for the CNAs, we did not exceed our budget. We actually, our budget was, for salaries not including benefits, $1,095,000 for the month. We did $1,018,000 in salary expense. So we're doing a pretty good job of controlling that. So operationally, basically, a year ago, we lost $7,100. Operationally, we're budgeted to make $50,000, and because mostly of this unanticipated increase in profitability and volume in the medical surgical unit, we made $77,000 from operations. You factor in the non-operating items, both property taxes and long-term interest, and we actually made 75 net, including that for the month. Our budget was 56, and a year ago we lost 104 in the month of September. For the 3 months, we actually, because we did not have a good month in August, and this was not happening. I hope we continue. That's why I say if we continue to see the swing bids in acute do something. We actually are $13,000 negative. Our budget was to make $171,000 for the 3 months, and the prior year we were actually at $9,000 or $9,800 negative. So we're coming back. Hopefully we will come back enough to move ahead of the prior year, even more than what we looks like we worked for the last month. Cash is good. It has always been good. We actually are setting right now, and I'm not going to go through the detail of it, but what I do want to do is tell you that we're sitting at over 100 with our reserves. That board has actually restricted for the construction. We're at over 135 days in cash. Okay, that's well above the standard. Let me just turn to that page, and I'll talk about that for just a minute. My copy. It isn't in your copy tonight, but it is in my copy. I'll do that. Days cash on hand for operations, just for operations now, 46.12. A year ago, days cash on hand for by the end of the same month, 10 days only. You have 46 days just in the operational items, meaning that we would have enough cash to pay for the items that take, the expenses that take cash for 46 days without going into reserves at all. The prior year end, we ended last year well, because of the supplemental, that was 48 days. The California average for critical access hospitals of operational cash is 23 days, so we're double that. And the national average for critical access hospitals is 24 days. Now, however, listen to this. Days cash on hand on all sources. This includes both operational and non-operational cash. We are at this point 71.5 days overall at this particular point in September. Our prior year we were at 40, so we're almost double again, with including the cash in the reserves. At the end of the year, we did kind of what we were supposed to, because we had that come in 74 days. The average for over all of critical access hospitals in California with their reserves, 67 days, and those include those that have large amounts coming in from property taxes, which we do not. And national average is 71 days. So we're actually at the national average or better for our cash, including reserves.
Good.
And so our cash is good. Our operations are the way they're supposed to be, certainly for September, and working the year-to-date to move forward. And that's my report, unless there are questions.
Questions, Director Bush?
On the, in the operating expenses, supply expense, is retail pharmacy inventory?
It's not the
Included in
inventory,
that?
what that is actually, is what they're using, okay? And so the situation basically is that, what we have found, okay, we just look at the purchases. But when we ended last fiscal year, they had a period where they had purchased a little more than what they normally had been, okay, in inventory. But then when we took the year-end inventory, which we have to do for audit purposes, we found that these things actually, the inventory was not as high, at least at the end of the year. So we had to push money into the expense side. And we took care of that, and we booked for it in the post-closing adjustments already for last year, but they did it again this year. And so if you see there, we're well under we're well over, I should say, our supplies expense budgeted. And that actually shows what they are using. Now, they should be over a little bit because their volume's over a little bit.
Yeah.
But they shouldn't be over as much as they are.
Okay.
So we have some work to do. Any other questions?
Well, looks like everything is pretty well on track, Jeff, for the month of September. The numbers are pretty close to the budget, so.
Normally we're getting there, and that's the whole idea on the operational side. How do we get close? You know, how do we budget to make it reasonable, make it a little bit of a push, but not so much that we're not going to ever make it.
Right. Thank you, Chad. Thank you. Okay, we don't have any old business tonight, but we have a whole bunch of new business. Item 1 is the, and all these are action items. Item 1 is the ACHD membership renewal, and I'll let Tim talk to you about this.
Yeah, this is, again, we participated with ACHD. This is the Association of California Healthcare Districts, which we've been a member of, I think, from pretty much the beginning, if I'm not mistaken. This is, again, our Alpha Fund and Beta, which are our general liability and our workers' comp coverage were ultimately a part of the ACHD family. And so forth. Those have both split off since then. And that's really kind of been one of the issues that I've seen recently. Again, ACHD, again, the board, they have an annual retreat that the board goes to, has been going to for a number of years, and so forth, and they usually get those at very nice places, and they had some great sessions and speakers that come in and talk and educate and so forth. And again, a lot of that was funded because of the financial strength of Beta and Alpha funds, both of those, and so forth. And since those have split away, we've seen a significant decline in the types of services that they provide, the quality of the services. You know, again, I think I was a little disheartened after I heard back, you know, what some of the board members went to. This year, they didn't even supply dinner at the annual meeting, and so forth. So everybody was kind of on their own, and so it just kind of caused me to go back and kind of relook at things. And I mean, a lot of the, you know, the advocacy, they were doing advocacy on behalf of the district hospitals before. A lot of that has fallen off. They don't do as much as they used to. A lot of that has now fallen into a different group, which we are a member of, which is the District Hospital Leadership Forum, which has been very instrumental in getting us a lot of our IGT money and helping us to maximize those things and so forth. And so I just, you know, again, the dues, we just got the membership dues that came through, and it's over $8,100 a year. And so I just really was putting it out to the board. Do you still see value for us to participate in ACHD? You know, we don't, you know, it's down as an action item. We don't have to make a decision tonight. Just really wanted to bring that to your attention, that we might want to look at that in terms of, because again, we pay a membership dues to participate with DHLF. It's obviously, it's a lot more expensive than this even, but you know, again, the financial wherewithal that we get is night and day. I mean, in terms of the return on that investment and so forth. And so just wanna go back and relook at that and so forth. There's lots of other opportunities for board education that we can participate in and take advantage of. But if this is something the board still wants to do, then we'll go ahead and just go ahead and process that and get that out. But, just wanted to put it out there for your consideration. That it might be time that we can get looking at whether or not it still makes sense for us to participate there.
Thanks for your honest evaluation of that. I trust your association with it to be a little more informed than.
They're good people and stuff
Well,
like
they
that.
are, yeah.
And I think, they really do try and, again, and I did hear some of the sessions were really good sessions this time, and so forth. But, again, just, there's a lot of, little by little, it's just been kind of keep cutting away at it and so forth, and just don't know if it's as meaningful as it maybe used to be.
The attendance this year down in San Diego was a lot less than prior years, but I did like some of the workshops this year compared to other years.
Yeah.
But I'm kind of interested to hear, because it was Director Parks and Director Elliott's first time at an ACHD conference. I mean, you guys had
I
any-
learned a lot. It was worth going to, and they're making changes. They're trying to get more regional rather than the whole state and local. And so they've got some good ideas. And for the $8,000, we can't lose. There is enough benefits there. The 8,000 is not anything.
Well, if
we can look at it during the year and maybe find something and plan and do something. But right now, to not do it wouldn't be a good idea. That's my opinion.
Director Elliott, just curious about what you thought of ACHD this year.
Sure. So I haven't been in the past, so I don't have a frame of reference to compare. It was worthwhile to attend the sessions, their annual meeting, but we're paying to attend that, and so the annual dues, I think, are a different question.
I think it was $1,000 per member to go.
Yeah.
The subset
Yeah.
was more expensive.
And I guess I would lean towards Tim's counsel on this. If we're losing value, if the association isn't providing value back to the district for the cost of that $8,000 dues, then we really should look at this seriously, whether we want to continue. If there are other organizations out there that are more effective at lobbying and more effective at getting what we need through the legislature, and this one isn't, then we should seriously look at that.
Could we get information on those other organizations? Because
Sure.
now I know about these,
Yeah.
this one, but I don't know anything about any of the other ones.
Yeah. We can certainly do that.
I tend to agree with Ross a little bit, if I may, that as long as there are alternative sources of ongoing, training and discussion, I agree. I've been to, I guess, 3 of these. Now, I did not go this year, but and it seemed like every year it was kind of a step down in effectiveness as far as I was concerned. But
Maybe we should look at some alternatives in the next meeting, decide, do we have time?
Yeah, I think we do. Again, it's just a question of us, setting the dues money and stuff like that. So, again, we have not sent a check out yet, and so we put that on hold. Obviously pending the conversation tonight, we can certainly hold that longer while we look at other options and plan.
Would they come get Chet if we don't send it in?
They might.
They're welcome.
will they come get Chet if we give them twice as much? In the grand scheme of things, when we're talking about, revenues and things, but, $8,000 and then the money it costs to send people to this, it's our job to be as prudent with finances as we can. Although we're on an upswing and things are getting more and more in hand and getting more control and things are looking more positive, if it means saving some money.
I will jump in there. What you're gonna find, I believe, from what I've seen at the other district boards, I have not seen them yet cancel their membership in ACHD. It is absolutely true that everyone is aware of what things have declined. Their focus pretty much now is the education of the board members. There are other alternatives, but most of those alternatives, if you're gonna have sessions, are gonna be online.
Okay.
They're not gonna be in person like that. So the question is being disciplined enough to go online and look at the things that you need to look at.
Well, it's
for
our
the
world
webinar.
now.
So,
Yeah.
I will tell you that most of the small hospitals, most of the small district hospitals are still participating, although they all have brought up the fact of the declining hearts and an increasing cost.
Yeah, I think maybe Chuck, what I would do is maybe it is this first step before we make a decision is I will reach out to the president of ACHD and share with them some of the concerns that we're hearing or that I'm hearing, you know, and maybe they're just not being told or whatever, and that, hey, we need to kind of see, you know, again, we have to, everybody, they understand everybody's in a financial crunch, you know, and that, you know, obviously they need to reassess the value of the organization to each hospital and so forth, and just to say, hey, you know, just commitment from you, this is gonna continue, it's gonna get better, or you're gonna be reinvesting into some of these programs and so forth, that it is worthwhile for our board members and for us to continue to stay involved, so.
I kind of wish that they would do like an exit survey kind of thing after the conference is over, saying,
Yeah.
what did you appreciate, what did you not appreciate?
I can bring that up, yeah, that's a great idea.
They do still have a non-member rate for attending the conference, so it's not
Oh.
contingent on being a member. It does cost a little bit more, but it's not paid.
If there's value in attending, because that's still open to us.
That's good too.
So we want to just table this till next
Let's
month?
do that, let me reach out to the
Yeah.
president and get back to you on his
Can I add a
comments.
couple other things after
Yeah.
Barbara's done?
I think
Passes.
that, as an advocate for healthcare districts both in, Washington and Sacramento, that we have an advantage because they are here in California. There's a lot of other companies that could probably, do a better job. I went to a lot of ACHD conferences. I have noticed with the last 5 years or so that they have a tendency to keep repeating the same topics at the conferences. But you've got to stop and think. There's that many new people that haven't attended, you know, at that time. So for a seasoned person, I think the challenge would be for us to, as Jean said, look at the other agencies that are out there and make a decision. But at this time, I think without having investigated it, I think we should stick with them because they do keep us in touch, and we need to be in touch. So I would move that we pay the bill this year.
Is that a motion?
Well, I think we're gonna look at it and try to get back to everybody
Yeah.
first, and then we can decide it next month.
Did you have something else, Ross?
Yeah, you know.
Well, I should
Well, I'm
say
sorry.
that the motion has died for lack of a second.
Okay.
So,
You know, I do want to note, I don't know if you're aware of this, Tim, but the executive director is retiring.
Mhm.
So they're gonna be without an executive director. They have, 3 full-time staff, which for a small association is a big cost, huge cost, compared to other associations, like the one I was associated with, we didn't have any full-time employees. So, and also when I was in the association business, I was always looking for partners in Sacramento to support bills, those that, you know, we share interests with. Never heard of ACHD once, ever. So it kind of sends me the message of they're not real active legislatively, even though they've got a full-time lobbyist that we're paying for. So I
agree.
I kind of fall back to Tim's kind of counsel on this, that maybe we really need to look and see if this is really the best value for dollars. We need to be involved in associations, clearly, I mean, that's how things get done in Sacramento, but maybe this isn't the right one, and so maybe we need to evaluate that. So I'm glad we're not gonna just jump forward to it, and we'll evaluate it later.
We need a motion to, table this until.
No, we'll just leave it, take no action, and we'll come back next month. I think we had a chance to investigate some of the other
Is
opportunities.
it tabled then?
Yes.
Thank you.
Thank you, Tim. The next item under new business is resolution number 1903. This is just a resolution acknowledging that we did contract review and policy and procedure, and we don't need to read the full resolution, do we?
No, you don't.
Okay.
You know, the one change was made in section D relating to contract approval and signature authority. Under the Healthcare District Act, the Board of Directors is the entity empowered to approve district contracts. You can delegate that authority as you wish, and you have delegated that authority to your CEO, so the board and CEO are the only two who can approve and sign contracts. The contract approval limit was previously set at $10,000. After governance, the recommendation was to increase that, excuse me, to $25,000. So you will see in sections D1 and 2. That's the only change to the policy.
And that was really in the event of an emergency situation that required immediate action.
Yeah, because it hadn't been updated in I don't know how many decades, actually.
Has there been a need to go to 25 from 10? What's causing us to want to do that?
10,000 is very, very, very low authority for a CEO. A lot of agencies do 100,000 or 250,000 just because it helps business move along quicker. So the 10,000 had not been reviewed in many years, and it was just time to update that amount. 25,000 is what governance settled on, which of course is within your discretion, but it's a very low amount.
Just give you
still.
an example again. This is really only for emergency situations. For example, if we had a crash in one of our drives.
No,
Huh?
it's not.
What?
No, this is just authority to approve contracts.
Well, that's different.
Up
We're
to
talking about the emergency. We're
25,000.
talking about number C here, letter C here.
Yeah,
was the
D is
emergency.
what we changed.
Can we change it to extraordinary circumstances like Tim just said?
Can you do what?
Change it to where, under extraordinary circumstances or where there's a real need, as opposed to, there's normally not a reason why he couldn't bring anything over 10,000 to the board and be timely.
Well,
I don't see the need.
well, part of it was actually because of the Erskine fire and the earthquakes. I mean, if you have an emergency, you can't come have a board meeting in the middle of a disaster.
It's just that contracts we should be able to look at. Example is our attorney. His is, what's his, 25,000 that we're approving now?
No, we're not approving his.
I thought his was on there, or was just approved.
No.
Okay.
That's for the revenue bond, not stuff.
When was your contract approved, Scott?
2013?
Was it this
That was
month?
renewed. I mean,
Renewed.
Yeah, that was
Okay.
earlier this year, yeah.
Okay, how much is it, 25?
No.
Oh, okay.
No.
But anyway, that, in my opinion, we don't need to increase it. If you already have the authority to increase it through John, if you need to, temporary. But, again,
Well, it is a resolution, so we do have to do a roll call vote. If there's any other discussion on that.
I have
Okay.
some concerns about it, actually.
Okay, go ahead.
I think with a contract for services, that we need to be more concerned really about the language of the contract than the dollar amount. It could be a contract for $500, and there may be something, services that we're buying that may be objectionable to the board, and I think if it's a contract for services, we need to look at every single contract. unless there's some emergency situation, but I don't think the dollar amount is the thing that, is the trigger for what makes it important to
I would
me.
agree.
You know, we're responsible for what happens in the hospital, and that dollar amount, to me, isn't the trigger. It's what are we buying for that, with that contract?
But right now, Tim can do a contract up to 10 without showing us anything.
Well, maybe we should change that.
Yeah, I agree, 100%.
I don't wanna make life
Can't sign any
difficult.
contract without review.
Yeah, I guess what my concern is that perhaps we should look at this and get a tighter control on contracts for services, unless there's an emergency situation. And for goods, you know, things that, supplies that need to be purchased for the hospital, yeah, up the limit to 25,000 or whatever reasonable amount is. That should be within Tim's ability to do, absolutely.
Can we amend that?
And so, I guess that's kind of where my thoughts are. Buy the stuff you need to run the hospital, that's fine. But if it's gonna be a contract for services, what are we getting, and what is it that, I think the board needs to really evaluate that.
Virtually everything comes through here anyway. I mean, anything for services and those kinds of things are coming through. We've got a couple tonight that are coming through. You know, it's like I said, we just don't go out and sign things. Like I said, I want your support, I want your approval, you know, because otherwise it'll come back on me.
Yeah.
You know, and so forth. I mean, there are times, like I said, with an emergency situation and so forth, where, you know, we just need to do that in order to keep healthcare services been going, you know, keep providing the care here and so forth, keep our systems running and so forth, where that may come up. But I mean, even, that's why that was my issue with here with the emergencies, that's really where that applies. And again, what that requires is that I immediately notify the board when I do that, and also set up a special board meeting to review it. So I mean, those things are in place with this and so
Yes,
forth, so I feel comfortable that
So
those
all
things are.
contracts-
It still all comes back to.
All contracts go
anyway.
to the board,
Yeah.
regardless of the amount.
They have to, we're a public agency.
Right.
Well,
Yes.
well,
Well, that's not what we're saying with
no,
item one.
he's been
They would still
approving
come
up
forward.
to
I would never
10,000
do
without
that.
submitting it to the board.
I understand, well, that would be
Yeah.
your practice, but this policy says you don't have to.
Right.
And I'm not comfortable with that.
Yeah, can we make it to where everything has to be presented to the board?
At least in my mind, for services.
Yes, right,
Not
right.
for purchase of goods.
Right, I agree. Can we make a motion to amend that, to see what you just said? I make a motion that we amend that to add.
I don't know where the other board members are, but
Well, I guess I need to ask clarification from Scott, do we have to not approve this resolution then? Because the general consensus of the board wants to amend policy and procedure, or?
So you can revise this policy however you want tonight and approve it.
Oh, you can, okay.
Yes, you can.
I agree with Russ, what he said. If he could repeat it, I'll second it.
So if it's reasonable for, you know, for contractual, things, items to run it through the board, but, you know, Tim is the buck stops there in the event of an emergency. I like him having that latitude, you know, to do that. 'Cause
Him and John could do.
I trust he's gonna do the right thing, and as he says, if he doesn't do the right thing, we'll find out.
So how about this? Because services can be a very broad term.
Yes.
How about if we work on the policy and bring it back next month?
Can't beat that.
yeah,
That'd be good too.
yeah. You know, maybe it's as simple as the contract's under 25 or under 25,000. Tim's authorized to sign for the purchase of supplies, goods and supplies, something like that. And don't even address the services issue.
Well, there's lots of other contracts that come into play, managed care contracts for pricing, you know, that are updated on an annual basis and stuff like that. I mean, you're talking about a broad range of the types of contracts.
Do those come to the board now, or you?
They have not, no,
Okay,
so.
okay.
They
So
will
we'll-
need
Those
to
are
be,
some more
they will need to
complicated.
be, yes. Yeah, you really wanna get into that.
Yeah.
So that's what I'm saying, I like, let's go back and maybe relook at this, revise this a little bit, and bring it back next month when we've got some better clarification for everybody. So,
Are you,
Yeah, that's good with you, Charlie. Yeah.
So we're not gonna take action on resolution, 1903.
correct.
Correct, okay. That will be added to old business, next month. Okay, item number 3 under new business is the bond refinancing. We want to welcome Mr. Gary Hicks, our financial consultant. Welcome.
Thank you.
We should have moved you up a long time ago.
See you, Gary.
keep you the very end.
The resolution that you have before you tonight with respect to the refinancing, I think starts on page 66 and goes over to 67. On page 65 before, there's a brief summary of that resolution. But if you were to look on page 66 and 67, the resolution basically provides for authorization of management of the district to pursue a possible refinancing of the outstanding 2003 insured revenue bonds insured through the Cal Mortgage or Oshkosh. It also refinances the loan that was done through what's called the Heathcliff program, which is the insurance program of the Oshkosh program. Back in 2010, the district was not able to make payments on the 2003 bonds, and so it actually entered into an agreement with Cal Mortgage to be able to fund or supplement the payments by the district to be able to make payments on those bonds, so they did not go into default. And so it actually is refinancing of both of those outstanding obligations. This is not a final resolution, this is very much preliminary, so it authorizes engagement of 2 parties, myself as a financial advisor to the district, and a firm by the name of Quentin Timmy, Brian Quentin in particular, to act as bond counsel on the transaction. There'll be a requirement if we do pursue that and go further on this and complete that, require the engagement of other consultants as well, trustees and verification agents and other parties as well in the financing, but right now just those 2 parties at this point in time. So the resolution items 1 indicates that it does allow for the preparation of an application to Cal Mortgage, which is kind of the next step to go through in the process with the refinance Cal Mortgage. Since this is only a refinancing, it does not include any new money, and we are not planning to finance any new debt at all, just the refinancing existing debt. It actually is approved by Cal Mortgage instead of through their normal annual meeting process or credit review. It's a desk review on that part, so it's not very time-consuming or difficult in the process. It does require an application process, and so long as there's sufficient savings in their mind, which is generally about 4% net present value savings on the debt being refinanced, they will approve those because it's in their benefit to be able to reduce the debt service, because in their exposure to be able to meet the obligation if you don't is actually improved in that situation as well as it is to the district. Item 2 indicates that you have the chief executive officer and the chief financial officer or their designees, along with myself as financial advisor, actually executing documents with respect to the insurance and the application to Cal Mortgage. Item 3 would engage me as a financial advisor to the district. Item 4 engages Quentin Timmy as bond counsel for the financing. And then basically item 5 is all actions by the officers, agents, and employees for this purpose of the resolution taken before are ratified, confirmed, and adopted. I think the last item, actually 2 items on the page 67, authorizes again the board president, the CEO, CFO, and other appropriate officers to be able to take any action that may be necessary to be able to basically carry out the intent of this resolution. And item 7 is that it's immediately effect on that. If in fact the savings and approval is received from Cal Mortgage and the savings is sufficient to be able to move forward, which is a minimum 4% net present value savings, we would come back to this board in either December or January for board meeting. Hopefully in December, but if things are delayed, then it'll probably be January board meeting as well for final approval. Only at that time it would be finally approved. My summary on page 65, I think pretty much summarizes that information that I just indicated from the resolution, but provides some additional information. It does indicate in the first paragraph that the debt being refinanced is both the 2003 revenue bonds and the Heathcliff loan that was funded, like I said, back starting in 2010, 2011. And, item in the second paragraph, it does indicate that the all-in interest cost on the new refunding debt is about 2.6%, actually 2.59 is indicated here. And that's based upon a 9-year maturity of that debt, so I think that would be maturing in 2028, the structure on that. In just a second, I'm going to go over some additional information that was provided. I think it's a handout for tonight's meeting. We'll talk a little bit more about that. So anyway, that's the information on the summary again, on that. Any questions with the summary or the resolution?
I was just gonna ask maybe Chet for just take a few minutes as to what kind of led us to this point in terms of why we want to do this and the benefits. Again, we've been pressed Cal Mortgage, obviously, because we had extra cash available, they want us to pay that down, and so they've had a financial, I don't want to use the word stranglehold on us, but you know, there's some certain limitations. I'd like maybe if Chet could just share some of those things that this would help us with as well.
We're getting down to the end of the time frame for our revenue bonds, for 2003 revenue bonds. They basically, you got about $2.2 million left. Half of that, again, that's over. It matures in 2021. So, by that token, it's a situation where normally we would go through that, and we're not really having any problems as we were when we did this Heathcliff note of paying whatever the payments might be, although we're only paying 50% of the principal per year, and we're taking a loan from the Heathcliff on the other 50%. But it's a present value savings really based upon the all-in interest rate, present value interest rate. And it's in addition, yes, there are some provisions in the promissory note from Heathcliff, from Cal Mortgage, where they have more control. They have an option if we have more than 60 days cash on hand, which you saw tonight when I gave that information, that we do, that they can request anything over and above that to be paid on the Heathcliff loan. They have, actually going back as far as we were doing the USDA application for the loan. The only reason, what I basically requested of them was that they wait and see if that went through. It did, and then because we had basically a $4.1 million amount that we would have to pay to put into that, to get that loan. They understood that, so they kept that in abeyance to see what would happen. I've convinced them the same thing on the grant, but how long that will happen, I can't tell you. I know they would like to, this is really a non-conforming note, if you will. They've never, said this in the past, they've actually allowed single unit not being able to pay the entire amount for that year, and then picking some out of Heathcliff. But the mitigating factor also for Hearn Valley is the fact that most loans, just like ours for the revenue bonds, require the borrowing of 1 year's principal and interest. That's about $1.5 million for current on our revenue bonds. And that was used in 1999 entirely because they made no payments for that entire year from the hospital. It caused a lot of upheaval in governance and other things for the district, and was looked on very adversely from the state. And so we don't have really anything to back us up. That's why I was able to get that loan from the promissory note from Heathcliff. But we would like to get out of that. We're in a different situation with cash flow. And so it's saving money, it's putting us in a position as well for the grant that we don't have as much of an encumbrance as we would have had, perhaps if we would have kept that. We don't have the, we get out of some of the control from Cal Mortgage. That doesn't mean that we're not gonna involve them in the state, we are. But they're not gonna have that same kind of control factor.
You'll
So-
be back in compliance
Yeah.
instead of
So
out of
how much
compliance.
how much have we been paying a year for the last 10 years toward paying off?
$1.5 million, but half of that, let's just break it down. Right now, it's a situation where the hospital itself pays about $1 million, and Cal Mortgage pays about $500,000. What that is, we pay all the interest and half of the principal, and they allow us to borrow half of the principal.
So we're skipping the payment.
We're not skipping a
Well,
payment.
it's sort of
All
like
that's going into the
effectively
trustees
Same thing.
and being
They're
paid to the
subsidizing
bond
portion.
holders.
Okay, so we've only been paying $500,000 a year.
No,
Effectively.
$1 million a year.
Okay, how much is the payment on the new loan?
About 950,000.
Okay, so
That's
it would
less
be the
than right
thing,
now.
same thing, but it's gonna take us 9 years to.
But we're
get
not
out.
borrowing the $500,000.
We're borrowing 7 million, right?
No,
Roughly 7 million, that's correct.
To pay off both of
the
those.
bonds.
Yeah,
Yeah.
again, there's no new indebtedness here.
Keep in
You're
mind the
paying off the
existing,
count, you're paying off the bond, and you're paying off the money that we currently owe.
The only
Cal
additional
Mortgage.
cost is the cost of the issuances,
Correct.
So,
the fees.
so I've got a problem with our process. We've come to this meeting with a resolution, all these agreements, move with this, it's not even been vetted by the finance committee. I haven't seen numbers, I haven't seen the details on what we're trying to accomplish, and I think that's why the board's asking questions of what are we doing here? I'm not familiar
What's
enough
the
with
other
this
options?
to act tonight. This is all brand new to me, and I wanna see why it makes sense, and I haven't seen that yet. It probably does, but I don't have it in front of me, so I'm not comfortable, moving forward with this. Not tonight, anyway.
Can we table it? Do we need a motion to table it till the next meeting and look at it in the finance committee and look at the options?
Well, while Gary is still here, I mean, this is an opportunity to ask Gary questions on, I mean, personally, I think it's a great opportunity to get out of Cal Mortgage. I mean, just to put it into perspective, I mean, when this district first applied for a revenue bond was the year that I was born. I mean, that's 34 years, I'm just being, sarcastic, but still, I mean, that's a very, very long time. I mean, it's, and I'm not saying that, I agree that, the board has the right to ask questions, but I'm just saying, I think it's a good plan to get out of Cal Mortgage.
What happened to the 4 million that we have tied up right now? If the grant doesn't go through and we're sitting just like we are, then we've got 4 million in our hands that we could have used to pay off something. Because we need to move on down the road and start making better decisions and making a profit with our hospital, which we're capable of doing. We're at the best times we could ever be with Affordable Care Act reimbursement. And we're not doing it. We need to do a better job. I hope that doesn't sound negative. It's a positive thing. We should be capable. Do you see what I'm saying?
not really.
Okay.
But I'd be more than happy to listen more and see if I can
Okay, the
answer any
Affordable Care
questions.
Act,
Okay?
we're getting almost 100%
Okay.
reimbursement as opposed to prior to that. We were existing prior to that. Where's the money that we're making? Where's it going? Are we not
well-
running our hospital properly?
Okay, we're kinda getting off track.
Well, no, that's,
Well, no, we are getting off track because we're talking about a resolution and what Gary is here for. I mean, we're not talking about the revenue in the hospital, that should be done in the finance report.
right, okay. What I'm saying is,
Maybe I can answer a few questions by going over the summary. Did everyone receive the handout that was for today? Let me just go over a couple of those items if I can and address maybe some of the questions because you're absolutely right. The question you should be asking is, what's the benefit of this? What are we getting out of this and what's our objective in doing the refinancing? Well, the first benefit you have, the primary objective, is to be able to get cost savings. So a comparison of debt service, so it reduces your debt service. As we talked about before, roughly your existing debt service is about $1 million a year, and the debt service you'd be having after that would be about $950,000. So it's a reduction of about $50,000 a year in your debt service payments. So it's actually reducing your cost of capital and your interest and principal payments, your debt service payments, with respect to the debt you have outstanding. There are two options we're looking on that. I can talk about that in just a little bit. The other options or the other benefits that you have is as indicated, your existing agreements with Cal Mortgage are out of compliance. So you're not really in compliance with those. And so Cal Mortgage, although they have not done this in the past, they've been a very good agency to work with. They provide you this Heathcliff loan, an interest rate of 5% interest rate, when the interest rate would otherwise have been 10%, twice that amount. And they'd actually provide the loan, which wasn't a requirement that they were required to. Matter of fact, I'm not aware they've done it to anyone else. So they've been very good to the district in past years. I know early on there were some problems with that and operations and whatnot where there was a lot of difficulty and a lot of, were indicated by Chet, there was a lot of problems associated with it. But over the last 10 years, very, very positive. In addition to that, it just brings you in compliance with your outstanding debt obligations. So you're not relying upon a government agency to do what you hope they'll do and work with you, instead of taking actions that they might have the right to, legally to do, that may not be in your best interest.
Would we be just as well off to pay the $4 million off and borrow $3 million? I mean, would that help us?
I'm not sure why you'd want to get rid of your cash. I think right now, cash is an important thing to have as a reserve, because you don't know what's going to happen next year.
What I'm saying is, we need to look at the options on what.
Well, I'm not in favor of getting the district more in debt, absolutely not.
And this is not
Then
proposed.
you wouldn't want his proposal.
No, it does not propose that.
No, it doesn't.
Does not.
This is a simple
Consolidated debt.
refinance option that will save us money.
Let me be clear. It's only the amount that you borrow is what's necessary to refinance the 2003 bonds, one, and two, to refinance the Heathcliff loan. Two outstanding debt obligations, no new money whatsoever.
That's what I'm saying, it's basically like a loan reconsolidation, basically.
It is basically
a lower interest rate, is really what
So
it
you're
is.
going, the interest rates on the 2003 bonds is 5.25%. The interest rate on the Heathcliff loan is 5%. The interest rate on here is about 2.6%.
What interest rate are we gonna get on the $4 million we got sitting there?
You mean interest income?
What does it matter?
We
We
don't
don't
get
have
much.
any interest on it.
It's in a money market, it has to be in treasury.
Right, but it's getting nothing effectively. Chet, you know what I'm talking about, I mean.
Well, I think the interest rate you get is through LAIF. I think most of that money is in LAIF, and I think the current interest rate in LAIF is around 2.5%. So not great, no, it's not what it was in years past, but a lot better than it was a year ago or 2 years ago when LAIF was probably around 20 basis points. But you're correct, it's not a significant amount that you're earning, but I think that's a different issue, I think. I don't think that you want to be in a position now to be able to deplete your cash reserves. And that would be my thought, is that, and certainly that's an option to be able to pay down your debt with your cash. That's an option you always have in that situation, and you certainly can do that. Cal Mortgage would probably be wanting to have you do that as well. And they've requested it probably, and I think Chet's been working hard to be able to make sure that that isn't used for that purpose.
Well, and that's part of the problem, is because our assets are tied up with Cal Mortgage.
That's exactly right, all your assets.
And this,
We haven't received
Nor
this.
didn't get that. I brought my copy, which I'm passing down, so apparently didn't get
I haven't
that.
seen this, and it answers a lot of my questions, but maybe,
That's why I thought maybe we'd want to talk about that. And that was something I just put together today, and the reason for that is I didn't have the information to do it before that, so it's relying upon other sources to be able to provide that information. But if you look down on the background, we've talked about the fact that your outstanding debt is at 5.25% and 5%, that the refinancing debt, all inclusive, is around 3% or just below 3%. So you have a savings of about 2 to 2.25%. The actual options you have show the savings on that. So under option 1 is where refinance the debt with the same maturity of the debt that you have outstanding. The savings is about $290,000 after cost of issuance. So that's the net savings after cost of issuance that would come to you in the way of reduced debt service payments.
Is that your consulting fee and bond counsel's fee and all the other consulting fees?
And all the other fees as well, that's correct, that's correct. So all the costs associated, there would be no out-of-pocket cost for the district to do the financing. Those costs would be refinanced, in essence, rolled into the debt that you have. But with that factored into that, the net amount of savings you have is $290,000. If you discount that back to today's dollars, so do a present value analysis of that cash flow of savings, it produces $321,000. So depending on whether you're looking at just cash flow over the life of the issue or present value, $209,000 to $321,000. If instead we repay it over a little bit longer term, which would front load the savings on that, would increase the savings in the earlier years as opposed to the later years. Actually, that'd be an actual negative savings in the later years. Your savings would be a little bit less, $147,000 after all costs of issuance, but your present value would be $335,000. So each of the options, whether it be to pay it off on the same term that you have on existing debt, or stretch it out a couple more years to be able to front load your savings on that, the savings is somewhere between $147,000 and $290,000 cash flow. Present value savings between $321,000 and $335,000. So in all situations right now, the debt service savings is actually an improvement. You actually get money, you're paying less debt service and a savings on that.
Okay.
Yes.
How would that affect us in the emergency room upgrade? That's roughly, is it?
Well, that's one of the
$8
reasons we
million?
need to keep our cash on hand, is,
Well,
need
well,
that.
4 million's not enough to do it. How would that
No.
affect the rest, another loan for the emergency room? What would we do?
It would actually improve your ability to get another loan on that because it reduces your existing debt service. So to the extent you can reduce your existing debt service, that provides more debt service.
Is that
more
what
debt
you're
capacity.
thinking, Chet, that we could do that
Partly,
and then refinance, or then
Yeah.
borrow on that?
It's partly the ability to, in other words, your debt capacity. It improves our debt capacity.
It does. Not a significant amount, but slightly. It is a slight
But
improvement.
it'd be better to have no debt.
well, it always is, but.
Well, I'm
but-
not sure that's true.
No, not in business.
But it
You
is
want
better
that.
to use your cash because then you just have to borrow more debt to replenish the cash you just spent down.
Correct me if I'm wrong, but the other side of this is that there are certain abilities from Cal Mortgage that they could impose on us
Yes.
that these would eliminate. This would eliminate, so that we are free and clear and out from under the Godfather.
Well, keep in mind,
With it in that vernacular.
we're still proposing that Cal Mortgage insure this debt.
Yes.
But you're in compliance, so they have no right to be
They have no,
taking
they
your
can't,
actions.
yeah.
That's
Thank
exactly
you,
right.
Mark.
So it does enhance your position with respect to the existing outstanding obligations and the requirements of the regulatory agreement and your agreement under the Heathcliff loan. Yes.
So we still under their requirements. Could we get the loan, would you, a separate loan for the construction? If we're still under,
This doesn't have much to do with
It
it, as
depends
far
on
as I
how
can see.
we write
on-
the agreement with them.
okay,
There will
well,
be,
see, we need all those, we need to
oh,
know.
but that won't happen until you start the process.
But I can say yes, let me answer your question, yes, you would be able to, so long as you meet the debt service coverage requirements. So the Cal Mortgage, what's called a regulatory agreement, has a provision under what's called additional indebtedness. So it allows you, without any other provision, to be able to secure additional debt so long as you meet a 1.25 or 1.35 times debt service coverage. So you have to demonstrate the ability that you have shown historically sufficient cash flow after meeting your existing debt and the new debt to be able to service all the debts that you're proposing to issue.
So far, they've allowed us, because they've worked well with us, worked well with me, I guess you'd say. They have allowed us to, for any new debt that I have to petition from them, even under the existing one.
What if that creditor comes and gets you and you're not here?
It depends on what, how they work through it, I guess.
Ross, do you
We let
want
him
to
take
talk
Barbara.
to the finance, to the next finance, or you wanna?
Well,
you got it.
you know, this information
Throw you under the bus.
is really what I was looking for. So in my mind, This is the Rosetta Stone here.
Yeah.
And I apologize for not having that earlier on to go in the package, I just didn't have the information.
So the length of the debt that we have now, it would be longer under this program, at least under option one?
Under option one, that's correct. Under one option, it'd be 2 years longer, and the other one would be paid off the exact same period of time.
So if we did option one, we're no worse off than we are today, but we have less debt
Yes.
because of the interest.
Well, less debt
rates.
service, that's
Less
correct.
debt service, yeah.
Okay.
But we're not
Now,
taking
the
on
other
any
thing-
additional debt.
The other thing, Gary, the 321,000 savings, that's on a conservative basis. It may be even a little more than that.
And it depends upon what the market does between now and the date that we sell the bonds, which is not planned to be until mid-January. So it does take time to go through the process and do that. It's subject to changes in the market interest rates. But yes, I think pretty much all the assumptions that we talked about are all very conservative assumptions for those numbers.
Well, I understand it now. I appreciate this information. Gene, I'm okay with moving forward with this in concept. It makes financial sense to me.
I mean, if you
And
really
again,
need
it's not
it,
the
we,
final approval either, because this is just to do
We
all
do
the front
actually have
legwork
detailed
to bring it
schedules
back
as
to you.
well.
So
We come back to you in December or January for final approval.
Yeah,
It is
yeah.
not final approval at all.
Yeah.
But we still have to pay your fees and everything.
You know, mine's a contingent fee.
Is it?
He works
My
for
fee is on a
both
contingent
the
fee.
attorney fee and the financial advisor fee is a contingent fee.
Gary's been here for 30 years at least, or 25
Yeah,
at least, a long
over
time.
30, yeah. But you would have to reimburse me. My contract says if it doesn't go through for out-of-pocket expenses, that's it. I will
Do
receive
you
no
have
fee.
deep pockets?
They're all
Travel
out-of-pocket,
expenses
so
to
you
get
can
here,
tell.
right?
I've emptied
Okay,
it right now.
yeah, Russ, you feel like it's a good deal?
I do.
Okay. You're the finance committee guy and.
Well, you're on it too, but
Okay, I know,
I've
but
changed
it's
my
not final-
position. But
It's not final approval.
right.
Right, this is just to start the preliminary process, as Gary.
It really is.
Yeah.
Okay.
And
After
I'm
all
sorry,
this time, can I make a motion that?
But
we
I
accept
just
it?
have one more question. I'm assuming that this is kind of maybe a timing of the essence issue, or is it just to lock in rates?
It is important for us to move forward, because if we can't get to the market in January, then we're subject to further possible movements in the interest rates. Right now, interest rates are fairly low, matter of fact, very low. And we do think that there's a window of opportunity. Now, whether that window of opportunity is available for us for a month, or 2 months, or 6 or 12 months, we don't know. But right now, we have a very good market allowing to be able to generate some savings. If we can generate the savings and provide the additional benefits on top of that, to me, it's just a win-win.
Okay,
I agree.
okay. So, are you okay with the resolution? Okay. Do I have a motion to approve resolution number 1904? This is the resolution authorizing the commitments and proceedings in connection with the proposed issuance of insured and refunding revenue bonds, authorizing the filing of an application with the Cal Mortgage Insurance Program and the retaining of the financial advisory bond.
So moved.
Moved by Director Elliott, is there a second?
I'll second.
Second by Director Bush. Heidi, would you please do a roll call for the resolution?
And this is resolution 1903, because you did not
Yes.
pass the.
Oh, I'm
resolution.
sorry.
Right.
Okay.
This is not final, this is just.
Right.
Correct.
Okay.
Excuse me, Heidi, resolution 1903 for the record.
Director Bush,
Yes.
Director Parks,
Yes.
Director Cassis,
Aye.
Director Elliott,
Yes.
Director Bly.
Yes. Okay, resolution number 1903 is passed.
Thanks, Gary. 1903 is an ending contract review.
Yeah.
It wasn't acted on.
Oh, because we didn't act on that one,
Right.
that one moved
Push
up.
back,
and
that'll
down.
become
Okay,
1903.
don't mind me.
The next item is the letter of agreement with Gary Hicks. And that's on page 68 and 69.
And if the board is inclined, you could approve both of these at once, since you retained them in resolution 1903.
Oh, 5 and 6?
Yeah.
To do it together as
You,
one.
you can, you don't have to, but you're
Okay.
able to.
Good, let's do it. I'll make the motion.
Okay, it's been moved by Director Elliott to accept items 5, Gary Hicks financial letter agreement, and item 6, bond council proposal with Quint and Timming. Is there a second?
I'll second. Oops.
second by Director Cassis. Any discussion? Hearing none, all those in favor?
Aye.
Okay, any opposed? That has passed. And last thing is, Director Parks, you wanted, you pulled the governance meeting minutes to talk about the strategic planning, and we'll get that.
Strategic planning. At the meeting, we talked about having them setting it up for April of next year, March or April. There's been so much changes, so many things happening, and the board, the only time the board can make decisions is when we're at this board meeting here, or the planning, meeting where the whole board's available, and we're not allowed to talk because of the Brown Act.
In spite of what the
We
public may
need-
believe.
We need time to look at what we wanna do with the emergency room, or what, or how we wanna do it. If we wanna put those trailers in, we need time and reasons why and what to do. And we need to have a strategic planning after we find out. If we get the grant, then we'll know how to proceed forward as a board, as a community. We need to have at least 4 hours or 8 hours at the senior center and have lunch brought in or something or whatever, but we have to have.
Yeah, I agree, some place that's nice where the public can.
Right,
get
the public can go there and sooner than next March or April, anytime after we find out if we get the grant, which is supposed to be the 15th of this month.
Well, I only suggested after the new year because of the
Oh, I
holidays.
know, annually, it would be good to have it at that point,
Yeah.
prior to the.
Doing the budget, it helps a whole lot.
Right, right.
Some of us are gonna be out
But now,
in December, so.
as a group and as a community, we need to decide what we're gonna do. We're sort of, things have changed and
Yeah, and,
So-
and, oh, go ahead, I'm sorry, go ahead.
so, we need to agree that we can pick a date, or somebody can pick a date after we discover what we're gonna do. But even if we do get the grant, we still need to have a strategic planning prior to next year.
And we need to know what we have done or what our constraints are.
Right, and just everybody look at it together. We can't do it now. Our hands are tied. And it's not a big deal. We just take a few hours to go down there and talk.
Part of it too, we want, again, in advance of Chet putting the new budget together for next year as well, because a lot of those conversations will
Yeah.
need to fund,
Yeah.
fuel right into the
It
fund.
should be
makes a lot
every
easier,
year.
it makes it very difficult,
Yep.
things change in midstream.
It
Right.
should be every year prior to that. But right now, we can't wait till next year to do what we need to do now. Because it's probably too late.
Actually, the budgeting process, I start at the end of January. That's how long I thought that takes, so.
And I
Hard to tell you.
I want to acknowledge that you probably know more about finance than I do.
All of us in the room put together.
We still need a motion to.
Unless Warren Buffett walks in the room
The
and then
minutes,
To approve.
because you pulled it off consent, so we have to,
Okay.
we still have to approve.
So we have agreed that we're gonna have it pretty quick.
We'll definitely have to put it on the new business for sure, yeah. So we can talk about it, figure out a location and a date and all that kind of stuff, yeah.
For next board meeting.
We can do it the next, if Heidi's okay,
If we have that
Tim's okay with that.
I'm, like I said, I will not be here at the next board meeting.
Oh, you have
I'm having surgery
that's
that day,
right.
so.
Okay.
God, any excuse.
I trust me, I'd rather be here.
Yeah, so we'll put it on new business, Heidi, for next month's meeting.
That's dragging it by one more month. Do we need to do that?
I tell you
I don't
what,
think that's a significant delay, but
Well,
I-
that's December 4th, then we got Christmas and we're into next year.
I think if we, preliminarily, we can probably agree that we should be able to put something together in the first part of January if Chet and Barbara begin the process of budgeting for fiscal 2021, 2020 and 21. At the end of January, then we'll have enough to turn over to them to
You know, I'm talking about
enhance their
strategic
decisions.
planning. We're not
Yes,
talking
no, I
about
know,
budgets.
I know. No, but strategic planning is going to
lead
be
to-
involved
What
budget.
into it.
If we
It's
say
not
this is
at all.
what we want to accomplish, we have to kind of determine, okay, what's this going to cost
But
us?
how long has it been since we've had a strategic plan? Most every board I've ever seen has one every
3 or
year.
4 years.
No, usually they're 3 or 4
Yeah.
years.
When's
It's usually
when's that the last time you had it?
Well, we're planning on having one now, so it's, we'll end the drought.
Okay, put it on for next month.
Okay. Maybe let's put it on for next month.
January.
Still need a motion to,
We can't have,
Approve the
we can't
minutes.
we can't vote on it.
yeah, we have
It's on the
to.
agenda.
Yes, it is. It's off consent. He pulled it
Oh,
off.
okay.
You got
So
two
we're
issues.
just approving that, the rest of it.
One at the minute.
Make a motion to approve.
Okay, so moved by
Second.
Director Parks, seconded by Director Cassis. All those in favor?
Aye.
Any opposed? Okay, the governance meeting minutes have passed. Item J is director's comments not appearing on the agenda. We'll start with Director Haley. Anything?
Thank you, Mr. President. Yes, I have several items.
Not always.
So I did attend the ACHD conference, and it was, it was decent, it was worthwhile, I'm glad we went, I'm glad, it was worth the expense in going for the district. I don't wanna go into a lot of detail, I just wanted, a few of the things I learned from that. Their inspirational speaker, the keynote speaker was a fellow named Johann Otter. He was attacked by a grizzly bear in Alaska. He severe trauma in a remote location, extensive rescue, and he's a healthcare provider. He's either a physical therapist or was a physical therapist, I think. So he works in healthcare, he works at Scripps, and so we got to see the other side of the perspective of being a patient in the healthcare system, and it was real eye-opening for him. So it was an important message, I think, to all of us. His main point was medical staff need to treat people, their patients, as subjects and not objects. Don't treat me as a sack of potatoes. I'm a person with problems. You're caring for me, and he wasn't being critical of healthcare. He said, I'm alive today because of the wonderful care that he got. But it was one of the lessons that he saw from the patient side is, I'm just a sack of potatoes. And so it was interesting to share with a bunch of healthcare folks. Legal update, the thing that kind of struck me, the chord there was, we probably need to be looking at, in electing board members, instead of at-large, at creating districts. There's organizations out there that are suing special districts throughout the state of California. They started with school districts, but they're working their way into healthcare districts. To make an argument, they're making the legal argument that we're not in compliance with the Voters' Rights Act because we're not having districts that respect minority voters. And so it's probably something that we need to put on our long-range radar and think about in the future. And then the strategic planning, as Gene was talking about, they talked a lot about that, and they encouraged boards to have at least 2 meetings a year, not necessarily to do strategic planning, but once you've done it, then talk about the implementation and how the achievement of the goals is happening, and keep it basically refreshed so it stays important. I did attend the ethics training certification I'm required to. Heidi, I have this for you. And I picked up this annual report. Petaluma Healthcare District does this annual report. And I don't know if we do one or anything like this, but I thought it was really attractive, and I have Debbie Hess's name on this one. So maybe look at this and tell us your ideas of whether you think something like this might be of value to us moving forward. So
It's nice when you're signing bonds as well.
yeah.
What are we getting for that? No,
So I don't know. I think it's a good way to communicate what we're doing with the great things that are happening in this district with the community. So, and also the reports tonight. I really appreciate the verbal reports from all of our management folks. I'm sorry that Judy Hyatt left. I particularly appreciated the foundation report tonight because she said all the good things that are happening at the foundation.
That's right.
Right on, that's so good. I was glad to hear that and kind of blown away at the depth of the foundation and all they've done, so, thank you, that's it.
All right, thank you, Director Elliott. Director Bush, anything?
For possibly the second time in my life, I have nothing.
Director Parks?
Ross said everything I was going to say. So, I'm sorry that you guys are here this late. A lot of it is my fault, so I apologize.
Don't be too hard on yourself, Gene. Director Cassis, anything?
I think we have to remember that we are elected by this community of population, and we also are the governing board of this district. And we do need to upgrade our bylaws, and in that, we can change the way we do business. We can change to include the public more. The public wants more. They want to be, we want more. We want to be able to talk without violating some conflict of interest or Brown Act. We know that there are rules in the state of California. We need to be able to, I want to say swing and sway with Sammy Kaye, but that dates me. I think that what was done tonight, I'm very proud of this board, because we've analyzed to the very max of anything and everything that came before us tonight. More so than in any of the history that I've sat in on. And Chet's can be a witness to that. We want an open board, we want the public involved, and we want to be able to govern the way it's supposed to be governed, and that's by people. Not by statistics but we are to be able to make the decisions and to be able to talk about them openly and make those decisions. And I think in order to change that, we have to do some changes within ourselves. And that is to maybe push the envelope a little bit as far as the not ethics or not Brown Act or anything like that, but we need to have more togetherness. We need to explore the minds of this board, because we got a lot of talent sitting here. I just saw that tonight, and I'm very happy to be here with them.
Now, you weren't talking about me too, were you?
Okay, thank you, Director Cassis. I just want to say thank you to the public and everyone coming out tonight. I know it was a very long meeting, but I think we accomplished a lot and talked a lot. So with that, I'll go ahead and adjourn the meeting at 8:25. Thank you.